welcome to this video blog on behalf of the African Journal of Primary Healthcare and Family Medicine. My name is Bob Mash. I'm the editor-in-chief of the journal, and I'm delighted to have with me today Sam Mulongo, one of our authors, who's just published a piece entitled Self-Reported Continuity and Coordination of Antenatal Care and its association with obstetric near miss, and this was done in Kenya. So Sam, so maybe before we get stuck into the actual research, maybe you can just tell us, who you are and a little bit about yourself.
Thank you very much, Professor Mash. Yes, my name is Sam Mulongo. I'm an educator in one of the local Kenyan universities, and specifically I teach community health nursing. My interests are in primary health care, and in fact most of my work is concerned with taking students for rural practice. And I also have a lot of interest in reproductive and maternal health care. So my current areas of research now have to do with continuity, coordination, and how they affect maternal outcomes.
And just tell us a little bit about your context, Sam. I mean, where in Kenya are you? What is it like there, especially for pregnant mothers?
I work in the Rift Valley region. So there are quite a number of large health facilities, but we also have certain regions in the Rift Valley, especially the arid and semi-arid regions, that record quite a high maternal mortality rate. As late as last year, the indices were about 340, I think, incidence of maternal mortality. So I work in a region that has quite a high burden of maternal mortality, and partly because of the distances and the terrain, some women still have big problem getting to health facilities.
Great. So this, as you said, is an important piece of research to prevent maternal deaths in your part of Kenya. So can you say a little bit more about what really was the aim and the idea, behind the research?
Thank you, Prof. So, in Kenya recently, about 10 years ago, we decentralized our services and we adopted the county system, and we are seeing a lot of layers of services, and we wondered whether these increased layers of services may lead to more fragmentation of services. And so we thought about the idea of continuity and coordination of care, because if we think about a pregnant mother, first we want her to be able to see the same healthcare provider across pregnancy. We also want her to have a good relationship with that healthcare provider, and we want her to have a smooth transition across points of care. And we know from other countries that these elements usually lead to better outcomes, perinatal outcomes. And so we wondered if in Kenya, because we are seeing a lot of fragmentation currently where one woman may see 3 or 4 healthcare providers across pregnancy, we wondered if this fragmentation may adversely affect her outcomes during labor and delivery.
Great. No, thanks. So just tell us very briefly how you went about sort of answering this question of, there was a relationship between continuity and coordination and near miss. I mean, maybe you could also explain what you mean by near miss as well.
All right. So what we did is that we focused on one big referral hospital in the Rift Valley region, which serves a lot of smaller clinics along its referral pathway. And then we categorized mothers into 2, the near-miss cases and the normal delivery. So near-miss cases here have to do with mothers who experienced a severe morbidity like eclampsia, severe sepsis, severe postpartum hemorrhage. we actually used the World Health Organization criteria for identifying near-miss cases. So we had about 97 near-miss cases and about 178 normal deliveries. And then we asked them about their experience during the antenatal period, the kind of providers they saw, whether they feel their care was well coordinated, and then we analyzed this data to see if there was a difference between the two groups. So we hypothesized that the near-miss cases would have had lower continuity and lower coordination.
Great. Yes. So Sam, thanks for outlining the methods, as it were. So what really then did you find? When you actually analyzed your data?
Thank you very much. So what we found in this study is that in the bivariate analysis, there was a relationship between continuity indices and near-miss, but in the logistic regression, there was really no relationship, suggesting that there are other stronger factors quantitatively related to near-miss, specifically the presence of a morbidity during pregnancy. However, if I can reference some other areas of my larger study, is that we had really interesting findings from our qualitative strand, which still point to how central continuity and coordination are. And I can give a few examples. We found that there was a breakdown in communication during emergencies. So the providers from the lower level facilities did not collaborate very well with their counterparts, which led to so many delays. Another example is that we found a lot of inappropriate task shifting within the peripheral facilities. So for example, you'd find that a nurse leaves their work to a cleaner, and which led to a breakdown in sort of parallel coordination or coordination within the peripheral facilities. And finally, something else that is central to coordination is that we found that providers in health facilities did not consider community health volunteers as part of the team. So this breakdown in collaboration resulted so the women were not followed up in the households because the work of community health workers is to do household follow-up. So generally from my other qualitative findings, it seems we need more research to, probably better quantitative designs to try and find a relationship between continuity and near-miss cases.
No, that makes sense. And so, just on that last point, maybe we'll finish with that. But advice for future researchers, you sort of alluded to the fact that if you had to do this again, maybe you would, methodologically do things a bit differently. Any tips there for future research similar to what you've done?
Yes, we think that that this kind of studies are best done with prospective designs because measuring continuity and coordination retrospectively has a lot of biases. So we know in some other countries we've used measures like insurance, information, and so on, but we need more robust designs to be able to quantify continuity and have that can show a clear relationship with the near-miss. And so, from a policy perspective, we think that increasing longitudinal continuity, we need clear evidence before the number of antenatal visits, for example, are increased. So we need clear evidence between continuity and near-miss. Thank you.
Great. Thank you very much, Sam, and good luck with your future research.
Okay, thank you, Prof.